This video is a Christian view of the controversial subject of gender identity.
So today I'm going to be talking on the ethics of gender-affirming care. So if you're older than 30, you probably think, what happened? Like, life was kind of normal and people disagreed and then everything changed. So I'm going to talk about the ethics of gender-affirming care. Before I get into the ethics part of it, I'm going to discuss some terminology and background and how things have changed. And then we'll talk about just an overview of gender-affirming care and then the ethics. So Steve referred to the DSM. This is the Diagnostic and Statistical Manual of Mental Disorders. It's kind of the psychiatry Bible that tells you how to diagnose different psychiatric conditions. And their terminology has changed. In 1980 was the first time anything was put in this manual relating to transgender. In 1980, the term was transsexualism. In 1994, they changed it to gender identity disorder. And then in 2013, they wanted to take that disorder out because they wanted to normalize it, so they called it gender dysphoria. And there was a revision made in 2022 where they not only added gender dysphoria in children, but changed some of the terminology. So instead of desired gender, it became experienced gender. Instead of cross-sex treatment, it became gender-affirming treatment. And instead of natal male or female, it became assigned male or female at birth. Now, I'm an obstetrician. I've delivered thousands of babies. I have never assigned sex at birth. I identify the sex, I announce the sex, I don't assign it. The other thing that's changed in addition to the terminology is the epidemiology. Epidemiology is like the demographics. So Dr. Willing referred to this, how it was very rare historically, about 0.0046%, so less than 5 per 100,000. And it also occurred, gender dysphoria, in two distinct populations. One was very young boys, what we call early onset gender dysphoria. And again, mostly boys, early childhood. So at the age of 3 or 4, they exhibited gender atypical behavior. And interestingly, most of these boys, if there was no intervention, they, with time, became comfortable with their birth sex. And the second group was late onset gender dysphoria. So this is usually adult men, often living for years as a heterosexual, married with children. So think of Caitlin Bruce Gender, Rachel Richard Levine. So these were the two main categories over time, very rare and either in very young boys or in adult men. Now the epidemiology has changed and we see this. It's not only become common, but now we see it in adolescence, something that is referred to as rapid onset gender dysphoria, although some would not even like using that term. And we also see that it's happening instead of in males, the majority are females. This graph here there's many versions of this from different countries, but this is the Tavistock Clinic in England, which is now closed, but you can see this is a graph over time of their referrals. And you can see how years ago there were few referrals, and this is just skyrocketed. And that yellow or orange is the girls. So instead of predominantly males, it's females. This book I would highly recommend if you want to learn more about rapid onset gender dysphoria. This is a book called Irreversible Damage by Abigail Schreier. So the other thing that's changed, in addition to terminology and epidemiology, is the standard of medical care. So historically, what was done in minors, in these young boys typically, is what we call watchful waiting. They would have a thorough psychiatric evaluation, they would receive psychotherapy, and they would be given time. But now, it's what we call gender-affirming care. That means the person is affirmed in their desired gender. There's minimal evaluation typically, and alternative gender identities are considered a normal variant, not a disorder. The thought behind this is that patients know what they need. So in gender-affirming care, this is used by most, probably every clinic, every gender clinic, and amazingly is endorsed by major medical organizations, the World Professional Association for Transgender Health, American College of Pediatricians, American College of OBGYN, American Psychiatric Association, Endocrine Society, on and on. So in gender-affirming care, the young person is affirmed in their desired gender. If a girl goes into a gender clinic and says, I'm a boy, then she is affirmed she is a boy. The healthcare provider is actually obligated to affirm the chosen identity. And the diagnosis is made by the patient and affirmed by the healthcare provider. Also in gender-affirming care, there's minimal evaluation and diagnosis because the diagnosis is made by the patient. So there's no external test or lab work or to make this diagnosis. It is depends on self-report. So the patient comes in and self-declares their gender, and then they are sent on a path of transition with little evaluation. This Do No Harm is a documentary by the Daily Caller that's free. You can pull it up. So this young girl who, she's a reporter. She's probably 25, but she looks like she's 16. And she goes into the gender clinic and says she wants to be a boy. She feels like she wants testosterone, and she walks out with a prescription. And we hear these stories again and again. So again, transition takes precedence over exploring underlying issues, and many of these people do have mental health issues, autism, history of trauma, history of sexual abuse, and they are sent on a quick path of transition. So just to overview gender transition, there's we think of it as 4 steps versus social transition, then puberty blockers if they haven't gone through puberty, cross-sex hormones, and what is called gender-affirming surgery. So social transition is we think of wearing the clothing or hairstyle or name or pronouns of the sex they want to be. Girls who want to appear as boys may do chest binding to make their chest appear flatter, packing to provide a bulge at the groin. Now, chest binding isn't just wearing a sports bra. It is really tightly wrapping sometimes with tape, and there's things you can buy, and most young girls report side effects from that. Boys may do stuffing to make them look like they have fat where women have it, and tucking, which is a very awkward, I'm sure painful, method to hide the penis and scrotum. If the young person hasn't gone through puberty, the next step would be puberty blockers. So this halts the physiological process of their normal puberty. The medicine is called a gonadotropin-releasing hormone agonist. So a young girl who's going to go through puberty, her body starts producing estrogen, and this blocks that release. Likewise, a boy going through puberty, his body will produce more testosterone. This will block that release. So it stops their normal puberty. And then they take cross-sex hormones to induce the secondary sex characteristics of the opposite sex. So a girl who takes testosterone is going to grow facial hair, have a deepened voice, increased libido, etc. A boy who takes estrogen is going to have increased body fat, decreased lean body mass, decreased sperm production, etc. And then some go on to have gender-affirming surgery. So a female who desires to be male may have a mastectomy, removing the breasts, often called top surgery. Genital surgery, called bottom surgery, so this is removing the uterus and ovaries, closing off the vagina. A phalloplasty or metoidoplasty, which is creation of a penis-like structure. Prosthetic testicles. A male who wants to be female may have breast reconstruction, facial and vocal surgery, and then genital surgery, which is removing the penis and testicles and constructing a vagina-like pouch. These surgeries have a very high complication rate. There's permanent disfigurement and detrimental sexual and genitourinary effects. Let me speak briefly about the World Professional Association for Transgender Health, which has produced these quote-unquote standards of care, and their guidelines have changed. Now, the WPATH is I would call it a pseudo-medical organization. It was started not only by physicians but by trans activists. So in 2012, their standard of care, 7, a person couldn't have hormones and surgery until the age of majority, so in the US that's 18. They had to have 1 referral letter, 2 for genital surgery. If they were a minor, they had to have parental consent, and their medical and mental health issues had to be well controlled. Just 10 years later, this is the current standard of care, version 8. They could have hormones at the start of puberty. Surgery, there's no lower age limit. No referral letters required. Parental consent can be bypassed. And interestingly, the mental and medical health issues don't have to be well controlled. They've changed the wording. They have to be addressed so that gender-affirming care can be provided. Well, that's kind of the background on gender-affirming care. Let's talk about medical ethics. As a physician, I have an ethical obligation to my patient. In medical school, we learn these 4 basic principles, what's called principlism ethics. The 4 main principles are beneficence, non-maleficence, autonomy, and justice. Beneficence means act for the patient's benefit. Non-maleficence means that I'm ethically obligated not to harm my patient. We often call this do no harm. I can't always help my patient, but I must not harm them. The 3rd principle is autonomy. So I must, as a physician, respect the patient's right to make their own decisions about their health care. And in order for them to do this, I, as a physician, must provide them adequate information, what's called informed consent. And the 4th principle is justice. So treatment must be fair, equitable, and appropriate. I can't treat one patient different than another. So is gender-affirming care ethically? I'm going to go through these principles. I'm going to talk about the first 3. The first 3, it is my contention that gender-affirming care violates the first 3 principles of medical ethics. So the first one, beneficence, do good to the patient. Is gender-affirming care beneficent? Does it do good? Does it help people? That's what we're hearing. Well, let me tell you where this started. The Dutch protocol. Again, this is very recent. This is a study. There's 2 studies that make up the Dutch protocol. The first one in 2011. This was in Holland. 70 young people were given puberty blockers. This is where they came up with this, well, if they're uncomfortable, we can block their puberty. And they evaluated the psychological effects of the puberty blockers over 2 years. Now, they had improvement in behavior, in emotional problems, depression, and general functioning. Although there was no change in anger, anxiety, gender dysphoria, or body dysmorphia. Then DeVries did a longer-term study that they published 3 years later, and they assessed the longer-term outcomes before puberty blockers, before cross-sex hormones, and then 1 to 2 years after surgery. They found in young adulthood their gender dysphoria was alleviated, and their psychological functioning had steadily improved. Now, in this second study, the first study had 70 people. This study only included 55 of the 70. 15 were excluded, some didn't follow up, some weren't eligible for the surgery, and 1 young person died of surgery, and they were excluded from the study. Well, there's some limitations. So you might say, well, this shows some benefit. There's some significant limitations of the Dutch protocol studies. First of all, this is a different population than the young people that have gender dysphoria today. In the Dutch study, these young people had gender dysphoria since early childhood, whereas today we mostly see it in adolescence. And really important is that the patients receive both psychotherapy and puberty blockers. So which one helped? There was no control group. What would have happened if they had no intervention? This wasn't a controlled study. And then, as I mentioned, 15 of 70 were excluded, 1 of whom died. 1 out of 70 young people died. So the issue with the Dutch studies, if the Dutch protocol was just an initial kind of pilot study upon which other studies, better studies were based, and we had better data after that, that's one thing. But these findings have never been replicated. and they form the foundation of youth gender transition today. Is there benefit from gender-affirming care? I could give several talks just on how there isn't benefit. The studies on gender-affirming care are low quality. We are lacking in long-term studies. There are no randomized controlled trials. And what we see now is that many experts have spoken against these treatments. We see that European countries have changed course. Finland, Sweden, many of these countries have stopped providing this treatment to minors because there is no reliable research showing benefit. So this is an article in the Wall Street Journal signed by 21 researchers and clinicians, people who treated those with gender dysphoria, saying gender transition, youth gender treatment is pushed without evidence. There were no US signatures. So in summary, the American College of Pediatricians, not to be confused with the American Association of Pediatrics, but the American College of Pediatricians is a conservative organization. There is not a single long-term study to demonstrate the safety or efficacy of puberty blockers, cross-sex hormones, and surgeries for transgender believing youth. So we're talking about beneficence. Is there benefit? And we do not have evidence that there's benefit. Well, I'm going to answer the question that's going to come up. Well, what about suicide? Because parents are told, well, do you want a dead daughter or a live son? If you don't let your child go through this, they're going to kill themselves. Well, what about suicide? First of all, we know that suicide risk is increased in transgender youth, 13 times higher, similar to other psychological disorders, anorexia, depression, autism, higher risk. And we know that transgender youth also have a higher risk of other mental health disorders, depression, and anorexia, autism. So the best evidence we have, this is one of the few long-term studies, suggests that gender transition increases suicide. This was a study in Sweden, evaluated all who underwent sex reassignment surgery over a 30-year period. They matched them to each person to 10 controls of their birth sex, 10 controls of their reassigned sex. 19 times the risk of suicide in those who underwent gender transition. Again, from the American College of Pediatricians, prevention of suicide for trans-identified youth is the same as for other youth. Talk therapy and FDA-approved psychiatric medications. So the first principle of medical ethics, beneficence, give benefit, benefit for the patient. Is gender-affirming care beneficent? No. There is insufficient evidence for any benefit from gender-affirming care. So I'm going to go on to the second principle of medical ethics, non-maleficence. So this is do no harm. And we hear this all the time in medicine. You know, you don't go trying something that could harm a patient. So do no harm. Does gender-affirming care cause harm? Well, and Dr. Willing alluded to this, there are harms from social transition. The social transition is not without consequence. Chest binding in girls, there's no peer-reviewed studies, but studies, one study indicated 97% had adverse effects, so back pain, shortness of breath, discomfort. Miriam Grossman, in her excellent book, Lost in Translation, says chest binding is like a gateway drug that sends them on a path. Tucking in boys, again, no definitive studies, but we have reason to think this affects sperm formation and fertility. And of course, social transition is difficult to reverse. Imagine a young person, a young girl who, for 3 years, socially has transitioned to a boy, and her peers know her as a boy, and then she just goes into school one day dressed as a girl. There is harm from social transition. Harm from puberty blockers. Puberty blockers cause decreased bone mineral density, loss of sexual function as an adult. They can cause sterility and neurologic effects. Parents are often told, puberty blockers, buy time. Well, just give them the puberty blocker till they have time to figure this out. Well, what we know is that many studies have shown 96 to 98% of those who take puberty blockers go on to take cross-sex hormones. So it sends them on a path. Cross-sex hormones. Is there harm from cross-sex hormones? Girls who take testosterone, increased risk of heart disease, stroke, high blood pressure, liver dysfunction, increased red blood cell concentration, adverse effects on lipids. Boys who take estrogen, increased heart disease, increased stroke, increased breast cancer, clots, benign pituitary tumors, gallstones, high triglycerides. Harms from surgery. And I know I'm going through all this very quickly because there's so much information, but removal of the breasts. Any surgery has risk of infection, bleeding. There's risk to any surgery, but I'm going to talk about specific risk to these surgery. The main thing with removal of the breasts is the inability to breastfeed. This young girl will never be able to breastfeed her children. Removal of the uterus and ovaries. So here I'm talking about the female to male surgical transition. She will be permanently sterile. She will never be able to bear a child. Decreased estrogen production. The ovaries produce the majority of estrogen. And, we think about women going through menopause at about age 50, but when you take the ovaries out of a 13-year-old girl, you're putting a 13-year-old girl through surgical menopause. Phalloplasty. This is creation of a penis-like structure. These surgeries have high complications, as high as 76.5% in one study. Urethral fistula, so this is a connection between the tube that empties the urine, connection from there to a different part of the body, 20 to 35%. Strictures, so closing off of the urinary stream, 18 to 25%. Graft site complications. Metoidoplasty is a kind of alternate procedure that has less risk, but still pretty high, and a reasonable percent of them still go on to have the phalloplasty. These are not the harms we see in typical surgeries we do in medicine, not this kind of percentage of complications. Let's talk about male to female transition. A male who desires to be female may have breast augmentation, vocal cord surgery, facial feminization surgery, genital surgery, so removal of the penis and testicles, construction of a vagina-like structure. So I'm going to get a little graphic here because I want you to understand what they're doing to our children. If a boy wants to appear female and wants to have a vagina-like structure, the most common way to do this is what's called a penile inversion vaginoplasty. Yes, inverting the tissue from the penis to make a vagina-like structure. Complication rate of 20 to 70%, and then they will need to go on in life dilating with vaginal dilators to keep the area open. And this can't be done if they took puberty blockers because there's not enough tissue. In fact, this is the procedure. The young person in the Dutch study who died couldn't have a penile inversion vaginoplasty, had a different kind of vaginoplasty and died. If they can't use that tissue, they will often take intestine. We're talking about taking bowel out and making it into a vagina-like structure. And in this situation, usually ongoing malodorous discharge. Again, significant complications, stricture, closing off, stenosis, fistula, a rectovaginal fistula. So this is a connection between the vagina and the fistula, and the rectum. We have inconsistent data on sexual function. So I ask, does gender-affirming care cause harm? Yes. Gender-affirming care results in permanent disfigurement and detrimental effects on sexual and urinary function. I'm going to go to the third principle of medical ethics, autonomy. Does gender-affirming care honor patients' autonomy? And you may think, well, certainly this one passes. So In autonomy, the patient can accept or refuse care. Doesn't mean they can have any intervention they request. So if a 13-year-old comes into my office and says, well, I don't like having my period, I want my uterus out, I'm not going to do it. That's not honoring her autonomy because it's not the right thing. But autonomy is dependent on the informed consent process, meaning the patient is given information about their illness, risks and benefits of the treatment, information about alternative treatment, including those risks, and they have to be competent to exercise judgment. So, for example, if a patient has cancer and might be cured with chemotherapy, they can refuse that chemotherapy as long as they're informed and given the information, again, the information, the risks and benefits, etc. Well, gender-affirming care actually bypasses informed consent. This is a paper by Levine and others reconsidering informed consent. So in this paper, Levine states there's 3 ethical concerns about informed consent in gender-affirming care. First of all, is the erroneous assumption that gender-affirming care helps. And we hear this often from patients. Well, I thought this would solve my problems. Number 2, incomplete and inaccurate information is provided. For example, the uncertainty of persistence. How do we know if you do nothing that this person won't resolve the gender dysphoria? And third is the poor evaluation process. As we've seen, there's very little evaluation. So interestingly, in gender-affirming care, they call the process the informed consent model. Well, the informed consent model is not informed consent. So in the informed consent model, which they present as informed consent, intervention is provided based on their ability to consent. Well, my 13-year-old asked me for a hysterectomy. It's not whether their criteria are met. No mental health evaluation or referral is required. The patient must attend 1 appointment. Mental health therapy is not required. This is, when I do intervention on a patient, I want them to know beforehand what I expect, how this will help. Well, no, this actually isn't going to help that. It will help this, etc. And of course, another big question is, can minors give informed consent? Because now WPATH says we don't have to have parental consent. Well, I know my friend who's a school nurse can't give a Tylenol without parental consent. This is from an article by Laidlaw and others, where they say children and adolescents have neither the cognitive nor emotional maturity to comprehend the consequences of receiving a treatment for which the end result is sterility and organs devoid of sexual pleasure function, to further argue that these adolescents should receive hormonal therapy without parental approval betrays a poor understanding of adolescent psychology and the role of parents in the family. Rather, it would constitute an unmonitored experimental intervention in children without sufficient evidence of efficacy or safety, for which informed consent, therefore, would not be possible. So, autonomy. Does gender-affirming care honor patients' autonomy? No. Patients are not given accurate information. Gender-affirming care is assumed to be the standard of care when it's not. Patients are not adequately evaluated, and they are not given informed consent. So in summary, gender-affirming care violates at least 3 of the 4 ethical principles. It violates beneficence because gender-affirming care has no adequate evidence of benefit. It violates the principle of non-maleficence, do no harm, because gender-affirming care does harm. And it violates autonomy because gender-affirming care provides inaccurate information and evaluation and bypasses informed consent. It is my position that gender-affirming care is unethical. It takes advantage of people in distress and the most vulnerable. These are young people who are often struggling with mental health, abuse, bullying, gender dysphoria. They need psychotherapy, support, time, not bodily mutilation. Thank you.